Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the New York State Health Foundation on New York's DSRIP program, a model for reforming the Medicaid delivery system. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's presentation. There will be a question and answer session held at the end of the event. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you take a moment to do this. I will now turn the webinar over to Allison Hamlin, Vice President for Strategic Planning at the Center for Healthcare Strategies.
Thank you. Good afternoon, everyone. Thank you for joining us this afternoon. New York is the latest state to receive approval to launch a DSRIP program. Its comprehensive initiative was approved in 2014 for over $6 billion and will be implemented in 2015, and just a few months down the road. New York's DSRIP model is unique in its inclusion of a broad set of health and social service providers and in the way it's being leveraged to drive true transformation in the delivery system and greater integration of services for Medicaid beneficiaries. During this webinar, made possible with generous support from the New York State Health Foundation, New York State Medicaid Director Jason Helgerson will provide an overview of the state's DSRIP model, and he is joined by his colleagues Greg Allen and Peggy Chan, who will discuss details in a deep dive fashion on the plan's financing structure, project domains, measurement approach, and evaluation criteria. Before we turn to the state for this deep dive, I am going to introduce in just a moment David Sandman from the New York State Health Foundation to give some introductory remarks and to lend the Foundation's perspective on the importance of the DSRIP initiative in New York State. And then after David's remarks, I will give a brief overview on the DSRIP landscape across the state and provide just some national context before we turn to New York for more details on its approach. So without further ado, let me introduce David Sandman, Senior Vice President from the New York State Health Foundation.
Thank you so much, Allison. We're very pleased to be supporting today's webinar on the New York DSRIP program. And for those of you who are not familiar with the New York State Health Foundation, we are a private charitable foundation that's devoted to improving the health of all New Yorkers, especially the most vulnerable. And we focus our efforts in three areas: expanding health insurance coverage, and so we've been very active in helping New York to implement the ACA. We also work on promoting payment and delivery system reforms, which of course is the focus of today's webinar, and we work on the prevention of obesity and its related diseases. So if you want to learn more about us or keep up with our work, I would encourage you to visit our website or to follow us on Twitter or Facebook. Given the Foundation's three priorities, it's natural that our state's Medicaid program is a key linchpin for achieving our mission. And by any measure, including enrollment and costs, our Medicaid program is just enormous. It serves over 6 million individuals annually, and annual spending on our Medicaid program exceeds $50 billion per year. So, just given its size and clout, New York Medicaid has an incredible opportunity to drive delivery and payment reforms on a wholesale basis. And to their credit, our state officials have been extremely ambitious in their vision of using Medicaid as the platform to drive change throughout our entire healthcare system in this state. And nobody just wakes up one morning and decides to do a DSRIP program. Of course, it is the latest in a series of reforms that are being undertaken in New York. We began this about 4 years ago with something called the Medicaid Redesign Team, which put in place a number of structural reforms to the program and got a lot of attention as well for enacting a global spending cap for Medicaid. Our state of New York has been very aggressive in embracing the health home program that's included in the ACA, and health homes really help to set the stage for the kind of collaboration and coordination that DSRIP is going to require. And DSRIP also aligns with and builds on other initiatives like patient-centered medical homes and ACOs and the CMMI State Innovation Model Program. So it really is a continuation of the journey that the state has been on trying to integrate services across settings and traditional silos. While DSRIP programs are tremendously exciting, they really are new and they are different. Earlier in the year, I attended a multi-state DSRIP panel at the National Academy of State Health Policy, and that old cliche was really true, that if you've seen one program, you've seen one program. I was, astonished to see how much the programs in every state varied, and we are very much in the process of learning what does work and what doesn't. New York was fortunate in being able to draw upon the lessons from some previously implemented programs, and we have included some unique elements that have not been tried anywhere else. And so in that very same spirit of learning from states who came before us, we hope that New York will inspire and inform the next wave of state DSRIP programs with similar aims to promote comprehensive payment and delivery reforms. So I just want to thank you all for joining us today. We have a huge participation rate on this webinar, so we know we have a lot of interest out there. Thank you to CHCS and to Jason, Greg, and Peggy for putting together a really great program. We hope that today's information is useful to all of you in your own work, so thank you.
Thank you so much, David, for those remarks. And just to comment on the interest in this topic, I believe at our last check we had representation from almost every state in the nation in terms of their interest in registering for this call. So clearly, New York has hit on a hot topic here, and there's lots of interest in learning from the approach that New York is taking to this effort. For those of you who are not familiar with the Center for Healthcare Strategies, we are a nonprofit policy resource organization based in New Jersey. We work nationally towards supporting delivery system and payment reform and broad quality improvement efforts aimed at improving care for recipients of publicly financed care, and most specifically Medicaid. We have the privilege of working with many of you in your home states and look forward to many more years of collaboration together, and appreciate the extensive collaboration we've had with our colleagues in New York State over the years. So what is DSRIP? Just to make sure you are on the right call. So DSRIP is the Delivery System Reform Incentive Payment Program. It's an incentive payment model that rewards providers for performance on delivery system transformation projects, specifically to improve care for low-income patients. These efforts are funded federally via Medicaid 1115 waivers. They're implemented on a state-by-state basis for states that choose to initiate DSRIP programs. And the goal is to shift hospital supplemental payments from paying for coverage to paying for improvement efforts. As David alluded to just a moment ago, there's tremendous variation across how DSRIP has been implemented across the states that have taken the initiative to pursue DSRIP programs. And the amount of funding that they have included has varied substantially as well. The projects and the milestones that are developed under DSRIP are state-specific, and generally speaking, states have tremendous flexibility to design and tailor a DSRIP program to meet their specific delivery system needs and interests. To date, the Centers for Medicare and Medicaid Services have approved 7 DSRIP programs. There are a couple of DSRIP-like programs that we refer to on this slide as well in Florida and Oregon. The first DSRIP program was approved in California in 2010, and since then we've seen, again, 6 other states implement these programs, with the most recent approval being that in New York State. And I would just note that the model in Texas has also been the focus of a lot of interest across the states in terms of learning and building from their model over time. So lastly here, just want to highlight a few trends that we've noted and that others in the field have noted as these DSRIP programs have evolved, and this will be our segue to the Department of Health team in New York. So again, since 2010, 2011, when these programs were first implemented, we've seen significant evolution with program requirements gradually becoming more prescriptive over time, learning from the experience and perhaps the need for more prescriptive requirements from the earlier implementations. More recent models tend to support wider scale payment and delivery system reform. to encompass a broader set of providers than just hospitals, including a range of not just healthcare providers, but increasingly providers from outside of the traditional healthcare system. And finally, we've seen an evolution towards more narrow, defined sets of project options for the participating providers. So with that, it is my pleasure now to turn to Jason Helgerson in New York State for our deep dive on New York's DSRIP program.
So, Allison, thank you very much for the first surprise. This is Greg Allen, not Jason Helgerson. As a busy Medicaid director, he got called to something but hopes to rejoin us very, very shortly. So I'm here with my colleague Peggy Chan, and we're hoping that Jason will join us very shortly. So on the first slide, we started with Medicaid redesign, and we really were facing, like many states, a situation where we had significant cost issues with the program, and despite spending a lot of money and watching that cost go up and up each year, we were also very concerned about the marginal gains we were making on the quality side of the program. And so when Governor Cuomo took office, we began in his first term to take an aggressive look at the way Medicaid was structured. The governor built a Medicaid redesign team. It was really the first time we'd ever tried to do anything like this. It was a massive stakeholder engagement effort, had a very sort of high-powered cross-functional team, met to chew on basically many, many recommendations that came from stakeholders from across the states, from the acute care sector, the long-term care sector, the behavioral health sector, from patients and patient advocates, many, many ideas that were then reviewed by this committee. And we had two phases of these implementation of these efforts that came from the Medicaid redesign team. So on the next slide, there were several reforms that were implemented, and with the highlights here are, number one, we implemented a global spending cap, and the idea here was that we would set a trajectory or a budget for ourselves that we had to stay under, and this became a public promise to our stakeholders that we would implement these reforms that would try to achieve fiscal discipline while improving quality. And we were actually, through the global cap and the implementation of several of these initiatives, we were able to reduce our annual year-on-year spending from 13% down to 1%, and we'll see some numbers on that in a minute. And we continue to live under this global cap. We monitor spending on a monthly basis, and we report it out publicly by sector against sector-by-sector targets, and we show variance in a report, and we actively track that with our stakeholders. Another key component is care management for all. So we took our existing care management programs and implemented massive reforms utilizing the Health Homes program through the ACA. And like in DSRIP, our care management activity really tried to drive towards a single point of accountability, and so we asked providers to come together in a network to do that care management rather than embedding care management in a single provider or single provider system. We, as part of that care management for all, we also were rolling out several managed care reforms to provide better quality management and patient tracking through managed care. We moved more members and more services into managed care, and we began to intensify our management of the plans around very specific benefits, and we're continuing that with a very large-scale implementation of a behavioral health carve-in that should be starting in New York City this April. And then lastly, we began working through patient-centered medical homes and health homes to try to drive better integration of care and improvement of better access to affordable, high-quality primary care, and then care management for those individuals who had multiple chronic conditions. Next slide. So we really were trying to make sure that we were operating a fiscally sustainable program, and we really wanted to avoid using the tools that we had historically used, which were tremendously disruptive but politically feasible across the board cuts. And so what MRT really tried to do was to create very targeted approach to spending reductions while we were also reinvesting some resources into better care, like enhancements to patient-centered medical homes and health homes, et cetera. And what we really tried to do was avoid that across the board, but the global cap did give the Commissioner of Health in this state broad authority to do across-the-board cuts if we had to, if these reforms did not hit our targets. Despite that authority, we've never had to invoke it because our projects that we implemented through MRT have been very successful in improving outcomes and reducing costs. We can look at the next slide. So this next slide, please. Okay, that's interesting. There should be a graph on this slide. Why don't we go to the next one? I don't know if our graph isn't showing up. What you should see here, maybe you can imagine it, is from 2013 through 2011, a line that's steeply going up as we're driving our statewide cost from $35 billion upwards to $50 billion, and then that cost leveled off considerably, especially on a per recipient basis. We climbed from 2003 to 2010 from $8,400 a recipient to $9,400 a recipient in 2010, and we are now back in 2013 down to $8,500 a recipient. So we have considerably drawn down our year-on-year growth in total spend, and we reduced our spending per recipient considerably, which allowed us to put considerable resources into the hands of the federal government to reinvest in our waiver. So we'll fast forward to slide 17. Okay, we're in a little bit of a different order here. Okay. So we'll fast forward to the waiver amendment. So there were several charts there that did actually show, and we'll try to work with Allison to get them out so everybody can actually see them because they tee this up very effectively. Over this 5-year period, we believe we're saving the feds about $17 billion in federal share of Medicaid. We're a 50-50 FFP state. So that means we've roughly saved equal amounts of dollars on the state side of this equation as well. And our waiver request from the governor to CMS was kindly allow us to reinvest a portion of that back. And in April, we signed a waiver request, the total value of which is $8 billion, and we'll break it down. What we really wanted to do was to go beyond MRT with these waiver resources and begin to look at more systemic issues that were facing the healthcare service delivery system in our state. We wanted to make infrastructure, service delivery changes, draw together the various silos of care, be those long-term care, behavioral health, the acute care sector, housing and other kinds of specialty and social services. We wanted to draw these together to build a better healthcare safety net. We wanted to continue to bend that Medicaid cost curve, and we wanted to pivot from a system that rewards volume to one that actually rewards value for all of our Medicaid members. So the next slide. So the amendment basically allows us a path or a channel through which to reinvest this $8 billion of MRT-generated savings back into the healthcare delivery system. And we create this federal reinvestment, $6 billion of which is financed through intergovernmental transfers, and another $2 billion are financed through DSRIP match or designated state health programs. These are funds that would not otherwise be matchable but are specifically approved for the purpose of creating this federal match. So the sources are generated through both IGT and DSRIP. And then the uses of these, we broke down $500 million for an interim access assurance fund, and this was time-limited dollars to help very financially struggling critical safety net providers in communities like Brooklyn, et cetera, where there's been several efforts to rescue very important providers in those communities. We clearly didn't want to have to use the performance dollars straight up to begin to do some of that, assisting those providers with the retooling necessary to put their financial house in order. So $500 million was sort of lifeboat funding with very specific requirements that the providers had to participate in the rest of the reforms required as part of the DSRIP program. We had about $6.5 billion that were straight up performance awards as part of DSRIP, which we'll go through in detail. And we had another $1 billion for health home infrastructure investments, building out long-term care workforce, and creating a menu of long-term services and supports or home and community-based services as part of our behavioral health managed care rollout. On the next slide, we show the principles here. You know, clearly we wanted our system to pivot to one that was more provider-centric and volume-centric, to one that really focused on improving patient care at its very core. We've been trying to be tremendously and painfully transparent through this process. There is not a day that goes by that we aren't sending out massive amounts of information to these performing provider systems as part of DSRIP, and those of you who have signed up to our listserv have given us comments about the volume of information that goes out. So our goal here is to put all the data, all the analytics, all of our plans, everything goes out publicly. We get public comment on just about every aspect of this, including aspects that are not required as part of the waiver, and all of the performance data is going to be made available. It's collaborative. You'll see in the way that we've built the performing provider structure, we are funding not systems of care, we're funding entire communities of care under these performing provider systems. And accountable, we're actually building a roof over each community in the form of this performing provider system, and that performing provider system is directly accountable to the state and CMS for the production of very measurable deliverables and for reporting out their relative performance compared to peers on important health outcomes, and dollars are driven by those outcomes. We also have a promise as part of this waiver that we will transform the way we do payments downstream through our managed care companies. And all of these payments we eventually want to pivot based on value instead of volume, and we are putting together a roadmap of value-based purchasing for our providers and plans. So the next slide, please. So I often say the blinking sign out in front of the DSRIP hotel is that we are going to reduce avoidable hospitalizations by 25% over the next 5 years. All of the projects that are built as part of our DSRIP, all of our efforts are aimed at that goal. That meant we did have to prune some ideas that had come through MRT that did not align with that goal, but CMS and the state felt that this was a very important one, particularly given that at one point Commonwealth ranked New York State 50th in avoidable hospitalizations despite all that spending that David Sandman was discussing earlier. So we thought this would be an important metric for us to work hard on. It's a statewide initiative, so unlike some DSRIPs, the public hospital systems are key to this, but we have also opened this up to a wide array of non-public safety net providers that are approved under a safety net formula. Our payments are all performance-based, whether those performances pieces are process or outcome, and you'll see as we go through this that we move gradually through the 5-year period to becoming exclusively focused on outcome payments. Providers have to develop projects, and we'll look a little bit at that based on a pre-selected approved list that the state negotiated with CMS that all came from our stakeholder engagement process as part of MRT, and they're arrayed in 3 different domains. And our key theme here is collaboration, and that is that we are actually requiring each of these PPSs to do a community needs assessment and build a network of community partners to implement the DSRIP projects together. The next slide shows our performing provider systems and sort of what they're nailed together with. So on the left-hand side, we have the partners, and this is not an exhaustive list, but they include our hospitals, our health homes, our nursing homes. We have a wide array of FQHC and non-FQHC clinics in the state, a big continuum of behavioral health providers, home care and personal care agencies. Housing providers are a critical part of this. Hospice providers are very important partners. The public health departments in each of our local counties are also participating very importantly in our population health management strategies. And we actually require, in order to fund even the planning components of this over the summer, that these providers came together in what we're calling a performing provider system, or a PPS. And they have to do 3 basic things. Over the summer, they did a very broad community health needs assessment, and they had to show us in this application they're going to be delivering to us this month that was based on broad stakeholder input and multiple sources of objective verified data. They then have to put together a DSRIP project plan, which takes its life in a DSRIP application that they're working on right now for submission to us. And they have to show that based on that needs assessment, they selected projects that aligned with the most glaring needs in their community. And then they have to operate these projects. Most of them are going to be working on 5 or 11 projects over the next 5 years, starting in April of 2015. And they have to, in a live database that we're putting up in our Medicaid data warehouse, they have to actively report on all their process and outcome measures, and all of these will be publicly available through a public portal. So the PPS is a very large entity with multiple partners that are all working together to implement DSRIP projects, and they get paid as a collective for achieving the goals that are specifically laid out in the milestones in this work plan. So on the next slide, we have just a high-level version of the work plan. This actually goes in about 5 or 6 other versions of the work plan, the biggest of which I think is longer than any scroll that's ever been discovered. We are all about work plans here, and we have at least 3 times weekly meetings on our progress with a broad group of stakeholders from across the state. But we have been in this planning and development phase that stretches from April of the current year through March of the next year. And through this, we've been doing all of our project planning. We issued planning grants out to the community. Project implementation begins in DSRIP year 0, which starts in April 2015. We all reflected at the state it was a little depressing to work for 2 years on a waiver to enter into DSRIP year 0. But we're very happy to be moving our way out of year 0, and pretty soon we'll be in DSRIP year 1 in operations. But it's been a lot of hard work. And if you're thinking about doing a DSRIP project, I'll just say there's a lot of hard work in the planning phase, and one of the nice things that CMS did for us based on their experience with DSRIP is to build in this relatively long planning window, which has been tremendously busy period of time, but very important to get this done right. And then the next 5 years, you can see we're moving from project design to project implementation and measurement. So the next slide, there's a lot of energy and a lot of statewide drama on the attribution process. And Jason has joined us. I did your portion of the slides, not as well as you would have done, but we're now on to attribution. So interestingly, Jason joined at the part where I probably would have been taking over as things would happen. But we're all to be flexible in state Medicaid programs. So Jason, is there anything that you'd like to say, framing, or should I just keep going?
I'll just finish up at the end.
Sounds excellent. So the attribution is the process by which we actually match a member on a one-to-one basis with a performing provider system. You can actually now take a college course in attribution here in New York State. It's a very detailed process. We think we've actually made improvements from some of the learnings that have happened here in state with our health home assignment, also tracking closely what's happened in the CMS ACOs as well. But what we try to do is to do a loyalty match based on access patterns for each member in Medicaid that meets a threshold of minimum utilization in any PPS. And we attribute them based on a logic model that assigns patients. We start out with developmental disabilities, move through long-term care, then behavioral health care. We have specific loyalty patterns for those 3 subsets. And then where most of our members get matched is sort of in the medical all other category, where we start with care management and we move down to PCP. Then we look at ambulatory connectivity, then ED connectivity, and then inpatient connectivity. So there is a hierarchical, mutually exclusive process by which we run a fairly complicated attribution engine that results in 2 kinds of attribution. One attribution that we use for payment, and another attribution that we're using for performance. And we'd be happy at any point to do a deeper dive with our partners on attribution. So on the next slide, we're just talking about the design grants here. So as I mentioned, we had an intensive planning phase, and one of the things that came up through stakeholder engagement and also from CMS advice was that providers needed some resources to pull these networks together, to begin looking at governance models, to actually build out these community needs assessments. So we began collecting these initial, we called them emerging performing provider systems. They had to give us letters of intent and then a preliminary network partnership list. And we began to cull those down into networks that looked more and more promising over time. And then over the summer, we funded in a couple of phases these design grants to help the providers do that community needs assessment, better pull in stakeholders, and then begin the selection and planning for specific projects. We broke those payments into two, and we set up deliverables that had to be met, showing that they were actually, working towards these goals in the design grant. And then everybody who gets a design grant that gets approved through the process has to submit a project plan application, which is due December 22nd. So we are very busy right now, as are the PPSs in our state. So the DSRIP domains are divided into four pieces. The first domain houses all of our project process measures. So this is where we, for each of the projects that are within these next three domains, we house the specific process pieces that measure their performance along this building of the DSRIP railroad. Domain 2 is where we house all of our system transformation projects. So this is our integrated delivery system projects, building medical villages, et cetera. So the focus in the Domain 2 is on the delivery system and the community of care as a total whole, and trying to drive together those, some call them silos, some call them cylinders of excellence, but we want to try to bring together the cylinders of excellence in a more cohesive whole, and the system transformation projects attempt to do that. Domain 3, the focus here is on the actual individual member, and so here's where we do all of our chronic disease management and all of our clinical improvement projects. Again, focus on the member that has a certain kind of chronic condition that we're leveraging out an evidence-based or an evidence-informed approach on. Domain 4, now the focus is the community itself, where we cast population-wide nets. So where the clinical improvement project may be to reduce asthmatic symptoms for the asthmatic population, Domain 3 will be working on reducing smoking in the community. So each PPS has to select projects in each of those three domains, and there's some guide rails for which kinds of projects they have to select. For instance, they all have to select a behavioral health clinical improvement project in order to be approved in their final plan. On the next slide, we just basically walk down that each domain has sub-strategies, and then those projects are organized under those sub-strategies, and then the DSRIP project plan flows out from that, and each project has clearly assigned process measures that come from the application and also from the PPS itself. And then all the outcome measures are pre-printed in our attachments to the terms and conditions of the waiver, and were negotiated up front with CMS, and most of which flow from data we're collecting now through our statewide performance program with the managed care plans. But there were several key measures that were added that were not in our current menu, but we are, for the most part, collecting all the data that the PPS needs for most of the administrative measures. There are a few that come from chart review, et cetera, that the PPS has to provide, and we are building some automated capabilities to collect that. And then there are also some financial stability metrics and system integration metrics that are part of that domain too. So on the next slide, we talk about the project plan requirements. So in order to select one of these now 10 to 11 projects that the PPSs are implementing, we require it to be overall a new initiative or substantially different from other Medicaid-funded or federally funded initiatives, so that they can build on to existing initiatives. So if they're implementing a collaborative care mental health project or some kind of other evidence-informed intervention, they can build onto that, but it's got to be a significant scoping up of that, either from new members, new providers, or both. But many of these are brand new initiatives for the PPSs. They also can be leveraging existing technologies and bringing them to other geographies, et cetera. They have to be documented to address one of the issues that was uncovered as part of that community needs assessment, And overall, we'll be looking in the application to make sure that each of the projects they selected represented some kind of significant change for their community or their providers. On the next slide, the other thing is we don't want this to sort of be a grant and then fold up the sidewalks. We want permanent, lasting change to be sort of woven into the fabric of the healthcare and behavioral healthcare service delivery. So we're looking for an ongoing commitment beyond the life of DSRIP, and we're looking for projects that have lasting effect, and that infrastructure has been brought to the fore to allow these kinds of technologies to continue. And we want to make sure that they are leveraging key existing capabilities like their patient-centered medical homes in their community, and we sort of inextricably interwove the health homes into the fabric of the DSRIP project descriptions to make sure that all the DSRIP PPSs had to work with their health homes. And again, we don't have to say this anymore because we're well past this, but we told people from the beginning that no application from a single provider would ever be considered, and now we're down to 25 or so PPSs statewide across the state, all representing even more of the categories that I went through on that PPS provider slide. So we are very heartened by the comprehensive nature of these networks that have come together and the collaboration that's resulted from the building of these networks. So on the next slide, next three slides actually, I think, I just try to give you a flavor. These are just samples of the projects. If you want to do some DSRIP reading afterward, I think the terms and conditions are interesting and the attachments are very interesting. They make for nice weekend reading with your family if it's snowing or something. But if you wanted to read one thing to sort of get to the New York State DSRIP program from the program lens, you may want to take a look at the project toolkit that's out on our website. It provides a detailed overview of each of these projects, and you'll see in this Domain 2 system transformation projects, we've got all of these efforts around building integrated delivery systems and drawing together the fabric of care, extending health home technology out to higher acuity patients, building medical villages, weaving together long-term care, more ambulatory care, et cetera. And we require that these applicants build Domain 2 projects. And then Domain 3, you get a flavor on the next slide that we build these out in these sub-strategy areas that are organized by chronic illness. But we have a set of behavioral health strategies. By the way, our most frequently selected project now, I believe selected by every PPS in the state, is the integration of primary care and behavioral health. So everybody is recognizing in order to reduce avoidable hospitalizations, at least in this state, I'm guessing in most of the other states that operate a Medicaid program and a safety net, we have to do a better job of integrating physical health care and behavioral health in order to keep people healthy and keep them out of the hospital, and that's been widely recognized here. And you have to pick a behavioral health project in the New York State DSRIP program. But then we go on with very specific evidence-based or evidence-informed projects for diabetes, asthma, and there's a variety of other categories. And then the last on the next slide is Domain 4, and we've got a series of population-wide strategies that map to an existing state prevention agenda where we work with our local hospitals and local departments of health and public health. And here we're casting this broader net and putting together projects that actually look at the community as the treatment net. And so where again we're trying to reduce underage drinking, promote tobacco cessation, et cetera. On the next slide, you must be getting tired because I am. Thanks for hanging in there. This just basically says that, you know, on this overall approach that we built with CMS, that in the early years, most of the money, 80% of the money in year one goes out against process. And by the end, 100% of the money in year 5 is going out on outcomes, whether those be population health outcomes, avoidable hospitalizations, or other clinical improvement measures. The way we measure performance here is through a reduction of gap to goal. So we set specific goals for each measure for each community, and then we ask them to increment that gap by 10% in each year, and we give a mathematical example here that I won't go through, but what it allows us to do is to reward performance that's based on where the current PPS sits. But we also then have a structure where there's a high performance pool that pays extra money for folks who get in the upper quartile of performance or who do extra well on a subset of behavioral health measures. But what happens is when we do our valuation, we spread dollars out to each PPS based on a variety of measures, and then each of these outcome measures gets a dollar amount attached to it in a time period, and then we increment the capability to collect those dollars on this gap to goal measurement. If performance dollars are surrendered because they are not achieved, they do go into that high performance fund to be redistributed to other PPSs or other measures that a given PPS is doing better on. On the next slide, we do a little bit more of a deep dive on the payment. So the amounts received are determined based on the performance of the providers engaged in the improved project and the PPS's overall performance in achieving the goal. So if you miss a certain amount of milestones, you can lapse your whole payment. There is a methodology to roll up sub-measures to a single achievement value, and that, for those of you who really want to get into the Zen and the Art of DSRIP, is laid out in Attachment I in the Terms and Conditions of the waiver. But we essentially assign a total dollar value to the PPS as a whole. We bust that total dollar value up by each project, and then we break each of those projects down into a life cycle of process and outcome measures. Those are further broken down into pay for performance and pay for reporting targets. And then in each quarter, we flow out the dollars into each measure. And then based on your achievement of each of those measures, you will either get that total award or you will not. So in each, for each measure, for each time period, there is a methodology to determine whether you've achieved that payment, but you either get 100% of that attached payment for that period or you do not. You can also get additional dollars from the High Performance Fund, and that's if the PPS closes the gap by 20% instead of 10%, there'll be a high performance increment. And then as I mentioned before, if your performance exceeds 90th percentile statewide performance for any specific measure, then you get that. And then there's a second quarter of funding that's made available in that High Performance Fund for high performance on behavioral health measures. There is a statewide accountability here, and the state is measured against a multi-point scale as a total state. And if we miss certain of these milestones on a statewide basis, then the statewide availability of DSRIP resource gets reduced proportionally across all the PPSs. So Jason's message, whenever I hear him talk, is that we're all in this together, that PPSs should help each other to perform very well, because if we start slipping, one slips and another doesn't, the statewide performance could ding everybody across the board. The next slide. So I mentioned some of this, but each PPS gets compensated for their project and the infrastructure development, and a lot of those are process measures, and then we migrate over time in this chart. You'll see it's broken down by the pay for reporting and pay for performance, and you'll see specific allocation percentages in each time period. And if you take a really close look, you'll see that over time we grow here to all of the money going out on outcome measures at the end, and 80% of the money in year one is pay for reporting on process. And then we increment in each year toward less pay for reporting and less process payment and more pay for outcome and more pay for performance. And again, there's patient experience of care. There's a very important woven in preventables that tier back to our 25% reduction, and then a variety of specific health outcomes as well. So the next slide talks about valuation. And the thing about this webinar is hopefully it'll create some thirst for more. We could do an attribution webinar. We could do a valuation webinar. We can do a metrics and milestone webinar.
Greg, we've already done it.
We could do more. It's so fun. So the Valuations based on all of these factors, and this is interesting, this construct that we worked out with CMS. There's, first of all, a project index score that is assigned to each of the projects, and the total possible points is 60 for each project, and there's a 5-point scale that drives how we create the index score. But think of the index score as a weight for each project. So our highest weighted project is the integrated delivery system, and our lowest weighted project is one of our community health, population health projects. So those are the transformational value of each project, if you will, is weighted. The next component of the formula is a PMPM. So when we multiply a statewide valuation benchmark times that project index score, each project then becomes worth a PMPM value for every member that gets served in that PPS. And then very importantly, the application score. So this application they're going to submit to us in December is going to be scored by an independent assessor. If they get a 75 on that application, then they're going to get 75% of the total value that would have been available to them had they scored 100. Doing a really good job on the application is important. And why is that fair? Because that application is the 5-year blueprint for driving the PPS in each of those projects. They have to give us an exact layout of exactly how they're going to organize themselves and how they're going to deliver each of those projects. So if you do a poor job of the application, that lives with you for your entire DSRIP valuation. So the way we calculate the maximum project value is we take that project PMPM that was based on an index score times that application score, so think of it as a percent out of 100, times the number of attributed lives. So that is very important. The larger the network, the more attributed lives each of the PPS gets, and then we multiply it times the 60 months of the project, which converts the PMPM to an annual value pretty much, or a 5-year value. So the take-home message here is that the number of members, the intensity of the projects you select, and how well you do on that project application drive your permanent funding for DSRIP over the 5-year life cycle. So there is quite a bit of energy in this state right now on trying to get the maximum number of members attributed to each network, which drives the PPS to establish a very comprehensive network and to outreach to all the long-term care providers they can, all the behavioral health providers, and very importantly, the PCP practices. And so every practice that we weighted highly in that attribution valuation formula has currency on the street in terms of working with these PPSs to transform the Medicaid system, and that currency is the number of Medicaid members that they are currently serving that they can bring into these PPS projects. So the very nature of the valuation drives the collaboration and drives the scope of the overall effort. So slide 37 just goes through the fact that there is this statewide accountability. We have to pass all 4 of these statewide accountability measures. They were carefully constructed. Sorry, it's on the next slide. Thank you. These were carefully constructed to be doable, but a stretch. So we have to actually change the healthcare service delivery system here. But if this penalty is applied, it reduces the funds, as I mentioned, in equal proportion. So all the PPSs are in it together. The next slide gives a little bit more detail on those statewide performance measures. And again, you can take a look at this afterward. I won't go through it in detail in the interest of time, but they were carefully selected to be good measures of, is the state doing a good job of transforming its safety net through the projects? The next slide talks about the evaluation, and we are implementing an outside valuation that's required by the overall terms and conditions of the waiver, and we want to be able to compare PPSs and see how well, in addition to the performance measures, how well did this do in terms of overall affecting the triple aim, and there's an evaluation that's set up to do that. And we're working also on getting stakeholder feedback on that evaluation design, make sure all eyes are on the proper evaluation. Next slide gives a little bit more detail on exactly what we're taking a look at. And of course, important in this is the extent to which we reduced avoidable hospitalization use, and hopefully some indications of what drove those key measures from a process perspective as well. What seemed to be the key ingredients in this recipe for those PPSs that did a better job on a case mix adjusted basis of driving down that avoidable hospital use. We are also required and are very happy on the next slide to implement a learning collaborative. And we are going to, we now have, thanks to our friends at CHCS and the New York Health Foundation, a rich history of doing learning collaboratives. We've been doing this in a health home program. It's been tremendously successful. Our stakeholders really like it. Our staff really like it because it's a very good way to get out a lot of information to a big group of people quickly. But it is required by the waiver, and will be, you know, there's detail in the slide on how we're going to be doing it, but basically it's a setting with which PPSs can share successful strategies, share challenges, and help each other in this sort of performance improvement community that we're trying to build as part of our DSRIP program. So the next slide is payment reform and value-based contracting. I'm wondering if, Jason, you want to take it from here. And
sure. Thanks, Greg, for doing the full parts. You can take a breather after having to go through all those slides. But, you know, I think first and foremost, I appreciate all the folks who are on this. You know, we've been living this project now and we started and worked on negotiating it for over 2 years and had many ups and downs, and then spent a tremendous amount of time earlier this year with CMS, actually spending a couple days in Baltimore face-to-face negotiating these details. So can appreciate how this is a lot to absorb in a relatively short amount of time. And of course, we're always more than willing to provide technical assistance to other states who are interested in following down this path. So in terms of payment reform, and this I think is really important, the infrastructure that we're building through DSRIP, and the way I always think about it is what we're trying to do with the waiver funds, it's almost like seed capital for, in essence, constructing the healthcare delivery system of the future. How should care be provided? And in New York in particular, and I think this is true across the country, we tend to have a healthcare delivery system that's out of balance in terms of what the needs really are. We tend to rely more heavily on institutional care, whether that's inpatient services or nursing homes, and we tend not to have enough of the sort of community-based services. We don't have enough primary care, we don't have enough community-based behavioral health services and the like. And so, and we're trying to launch these initiatives in ways that will help in rebalancing that delivery system. But at the same time, the concern is if we don't change fundamentally how we purchase healthcare services, when we come out the back end of the waiver period and those funds are no longer available, we won't be able to sustain the infrastructure we built. Because the payments will continue to be on this fee-for-service basis, this episodic basis, and will actually not be flexible enough to actually pay for and sustain this new healthcare delivery system. So we and CMS felt very strongly that we had to develop a pathway to meaningful payment reform. And we're actually, in the terms and conditions, and Greg went over it briefly, is that one of the key deliverables we have is to move forward with payment reform and value-based contracting within the construct of our managed care contracts and submit a roadmap to a reformed, in essence, Medicaid managed care program by the spring of 2015. And in fact, if we don't submit this and get it approved by CMS, CMS will not approve any future starting in April 2015, managed care rates, which would bring our program, which the vast majority of our population is in managed care, and bring the whole Medicaid program in New York to a screeching halt. So it's a very, big hammer over our heads that we need to deliver on in terms of meaningful payment reform and value-based contracting. We actually believe in this holistically, and in fact, we were the ones who suggested that we set a goal for ourselves that 90% of all Medicaid managed care provider payments, those are payments from the MCO to the providers, would be on a value basis by the end of the waiver period. That is extremely ambitious. We're a $57 billion enterprise, and to imagine, and certainly by the time we get to the end of the waiver period, virtually all our money will be in managed care. To imagine an environment where $50 billion is going out on value basis That's a very significant change, not just for the Medicaid program, but potentially for the entire state's delivery system. We also are interested in taking this discussion beyond the Medicaid space. We have a state health improvement plan application into the federal government. Key part of that is multi-payer payment reform. So we're interested in doing sort of a two-phase implementation here, first focusing on Medicaid and then looking to see what we could do in collaboration with other payers, so that particularly in those communities where Medicaid is a smaller part of the total healthcare expenditure pie, to see what we can do together to collectively not only maintain the infrastructure, but actually further deploy it to communities across the state, to a wider array of the 19.5 million people who live in New York State. This will be a multi-year plan. This is not a light thing to be taken. It is going to require a tremendous amount of change on the part of providers as well as on the part of plans. We don't want to push providers into payment reform faster than they are capable of doing it. And I'll talk a little bit about the array of options that we're looking at in terms of the structure of those payments. But we are, in essence, creating a menu of choices, but that menu would be sort of laid out over a continuum with certain types of payments being seen as, well, a move in the right direction, not the sort of ultimate goal that we're working towards in terms of what we're looking for in terms of long-term sustainable payment reform. All this must be approved by CMS, and we will be not only developing this initial multi-year plan, but we will constantly be updating this and engaging stakeholders in not only the upfront development, but in maintaining it moving forward. So go to the next slide. So this is, in essence, a simple schematic meant to try to explain what we mean by payment reform in the context of DSRIP. This little chart here has generated a lot of buzz all across New York State in the sense that the vision here is that the managed care organizations are contracting directly with the PPSs, and then within the PPS are a whole wide array of providers, as we have been building all over the state. And that PPS in this example is receiving potentially a single bundled payment on a per member per month basis, a sub-capitation payment from the MCO to meet the holistic needs of the Medicaid population that they serve. And in essence, that simplified version is what I think has created all the buzz here. This idea that an entire community of providers, and some of our performing provider systems are a single performing provider system in a community. To think of almost a global cap on Medicaid expenditures in a community, and then the CAC community having tremendous flexibility in terms of how to use those funds to best meet the needs of the community. To start thinking beyond traditional healthcare services to other types of services, public health interventions, whether it's housing, nutritional support, employment training, other things that we know historically aren't things that Medicaid could pay for, but there's clear evidence suggests that for subsets of the population are what's going to really make the difference in terms of controlling healthcare costs and improving patient outcomes. To us, it's very exciting to think to have that kind of flexibility and allow these communities to design the systems around these populations that really best meets the needs and is in a very patient-centered, patient-focused fashion. But that said, that's sort of the far end of the continuum of options that we see. We see the MCOs also breaking up that total compensation into component parts, looking at bundled payments in certain areas like maternity care, where you could do bundled payments that incentivize subsets of providers within the PPS to be very effective at preventing bad birth outcomes and trying to minimize C-section rates and trying to get more full-term births. You could also envision payments where you could really align in terms of primary care providers who want to keep things as simple. They want one set of incentives, they want one set of reporting requirements, and they want, as opposed to an environment where they have to contract with multiple MCOs in different ways around improving quality as well as controlling costs. So I think there's ways within this construct, and that's what we're actually in a listening mode now, meeting with stakeholders all across the state, and we'll have a more formalized process starting in January to engage the stakeholder community to really provide this continuum of options that the PPSs and their providers within the PPSs as well as their managed care partners will be able to begin to look at and begin to contract around. It's a very important component of this initiative. If we do not move forward with payment reform, we risk losing all the gains that we make during the waiver period in terms of the changes in this infrastructure. So it's really important for us to move forward on that. And then if I could just finish up with just a couple of other comments in terms of, looking back, taking a step back, looking at DSRIP, looking at the path we've been on for the last 2 years, in particular the path we've been on throughout calendar year 2014. Just a couple, I would say, almost like bits of advice. Piece of advice number one is communication, communication, communication. DSRIP is complicated by its very nature. As we are on slide 42 of the presentation, and if you go out to our website, you will find many, many challenging issues that folks need to grasp and absorb. And I think you have to think long and hard about how you're going to effectively communicate this initiative to your stakeholders. DSRIP, anyone who follows on our path on DSRIP and proceeds forward with this in CMS, they will look to the most recent state, New York, as and Massachusetts as the ones who will sort of set the bar for the next state. So there's a lot to learn from us, I think, but you'll be almost certainly expected to do more. And it's going to be a challenge, as it has been for us, for you, to communicate out effectively. I think you have to think about non-traditional forms of communication. I mean, we're the kings and queens of webinars and PowerPoint presentations, but we've had to sort of spread our wings and think about alternatives. We've done about 6 whiteboard videos, an idea we stole from the federal OMB, short videos, less than 5 minutes, trying to get at key points to try to explain complex principles simply to a broad audience. We also now have what's called the Mix, which is an interesting deployment of or basically a crowdsourcing type software. The idea is first time it's deployed in government. It's an opportunity for people from a diverse set of organizations to come together and feed off each other in terms of ideas. It's in the early stages of deployment, but we're excited about it. But we really are working hard to try to provide and communicate effectively so that people can understand, absorb this, because if they don't, they're not going to be as successful as we need them to be in terms of implementation. Second thing I would say is staff up. Waiver funds can be used for staff, and do not take this opportunity lightly. We brought in 2 contractors, one required by the SDCs, which is the independent assessor, and then we have a separate contractor, we call it the DSRIP support team, that has helped deploy very quickly staff all across the state that are working with the performing provider systems on a regular basis. We're also building a staff, and Peggy Chan, who was hired specifically to be our DSRIP director, and she's in the process of building a state staff. So you want to have people on the ground helping, providing information, receiving information, providing clarification. It's a tremendous work, a lot of people involved, so you don't want to be short on staff, and CMS is open to using waiver funds for that. And then lastly, if you're going to pursue a path similar to ours, where you're trying to bring these large groups of providers together in communities, you have to be prepared to work as a marriage counselor. I have been providing that role, and others working with me have been serving that role. You would be amazed, some of you maybe less so than others, would be amazed at the degree to which there's animosity out there in the healthcare sector where providers really don't like other providers, or there's a lot of bad blood that's been built up over many years. I would say healthcare is an interesting marketplace, and particularly interesting marketplace in New York, because it's dominated by not-for-profit, many religiously aligned organizations who compete like heck for business and have for decades. In a market in which over 50% of the money comes from the government. It sort of has some interesting market components to it. That said, it is what it is, and so you have to deal with some of this history. And we have spent a tremendous amount of time traveling the state, meeting with these providers, trying to convene them to try to get them to work together. It's a tremendous amount of work to do, but I think at the end of the day, we've had some great success stories so far in terms of providers really coming together to do this for the right reasons, and I think at the end of the day, the program's going to be stronger. And so then lastly, just some lessons learned from CMS. What we originally proposed over 2 years ago, actually we're starting to get closer to 3 years ago, I have to think about it, is that we proposed what we thought was a pretty straightforward, simple design, which was 13 grant programs designed to do a variety of different things to meet where we saw were basically the gaps in our delivery system that prevented the Medicaid population from really achieving our ultimate goals in the triple aim. That flexible model was to a great extent built off of a previously approved CMS waiver called, we call it the HEAL program, or it was called the F-sharp waiver that had been approved a few years ago and actually had been renewed by CMS within the last 4 years. And so we use that as our experience. And what we found is that when we initially proposed that, we ran into, I would call it fairly, call it a brick wall in terms of trying to get CMS approval of it. They had very much migrated or moved on in terms of waivers from where we were originally. And back when we had ours approved. And they were very interested in this DSRIP model. And eventually, after some back and forth, sometimes not all that constructive, we in essence acquiesced and adopted the model. We attempted to adjust the model to really reflect our original intent because we had built our initial proposal around a major stakeholder engagement process. We wanted to stay true to that. But that said, we had to basically, dance to CMS's tune in terms of the structure of this, and we did so. I think at the end of the day, and Greg and I and others have had this conversation, that we think that going through the process with CMS, we actually do feel that at the end of the day, the overall structure that we have here is actually probably superior to what we had originally proposed. While it's much more complex and challenging to implement and to explain, we think that the accountability that's built into it, the transparency that's built into it, and the longer-term nature of it in terms of payment reform being so front and center. While payment reform was always something we wanted to do, the fact that we're really locked into it as part of the terms and conditions of the waiver has, I think, long-term for us a lot of benefits. And so while we were maybe perhaps dragged a little reluctantly to the altar, to use my marriage analogy to keep going further, is that we, I think at the end of the day, feel that what we worked out with CMS is in the best interest of New York's Medicaid population. Next, accountability. I mean, it's a huge leap from where we were when we launched the HEAL program quite a few years ago here in New York State. It was really a grant program. If you looked at the terms and conditions in the waiver in terms of how that was governed by the federal government, it was maybe 2 or 3 paragraphs. And now we have 100 pages of terms and conditions. We have multiple attachments. We have multiple additional protocols and reports that are all approved by CMS, so many governing documents. The level of change has been tremendous. We're also the first state from DSRIP to be held accountable on a statewide basis. It was clear CMS wants to take this, not just for the performing provider systems to be accountable, for the state as a whole. So that was a significant change. I personally think that that's a good thing. As I like to say, what happens in the Bronx matters in Binghamton and vice versa. So we are all in this together. We have to do those learning collaboratives that Greg was talking about. We have to share best practices. I hope that this can unite the communities across the state to really see how we can work together as a whole to best meet the needs of Medicaid members regardless of where they live in New York State. In terms of targeted proposals, we want this initiative to work in every single community based on the needs of that community. That's why the health needs assessments were so important. It's a major part of this process was to do those and then choose projects that reflect the community needs. No two communities are alike. We chose not to define the communities. That was one of those decision points that we, as we were developing this, our option could have been to define the geography and said, okay, providers come together in those geographies. We decided to take a step back and allow the providers to do it themselves. Overall, we think that the divisions that have been created are good ones. They are almost certainly different than we would have created ourselves. It did create some animosity. There's no question. There's been some infighting between the PPSs in terms of trying to build their networks, including providers. I think at the end of the day, we're better for having, in essence, to great extent, these are coalitions of the willing as opposed to being forced together. We did, as we say, do some marriage counseling and try to encourage people, but in most cases, these are all folks who are signing up willingly to partner with one another. And then lastly, and I always emphasize this would not have happened if Andrew Cuomo, the governor of New York, had not gotten involved. He personally advocated multiple times to the Secretary of Health and Human Services to others, including going all the way to the White House to get this done. He committed to, he identified the need for the waiver. He committed to the healthcare community who had gone through a very challenging process in terms of trying to make this program financially sustainable, and we achieved great success. But we always knew that if we were to achieve our ultimate goals, the triple aim, that we needed to invest dollars into the delivery system to make it much more cost effective, and that we couldn't do that on our own without this waiver. And he spent a tremendous amount of political capital in getting this done. And while all of us who are Medicaid directors or working with CMS, there's a limit to some extent of what we're able to do. And it's important to make sure that your governor is engaged fully and on board and excited about it, because he or she can really help make or break this. They have to be the top advocate for this and the reasons why it needs to get done, and we certainly had that here in New York. So that, I think that's it for us, and I think there's a couple slides for CHCS.
Great. Well, thank you so much, Jason, Greg, and Peggy. We know you're there too. We really appreciate it. I feel like we've all just been to like the unlimited DSRIP buffet and are all feeling pretty stuffed, most likely. But tremendous amount of information in a very condensed amount of time. And on behalf of all of the participants, I know we all appreciate it. We do have about 15 minutes for questions, and we have received quite a few written in and submitted over the course of the webinar. We encourage those of you who are on and have questions that you want us to field on your behalf, please to submit them, and the instructions for doing so are on the screen in front of you. Just to start us off, a couple of just housekeeping notes. Many of you have requested links to some of the information that Jason and Greg have presented and referenced during the course of the presentation. We will make sure the link to the DOH DSRIP site is shared around to everyone, and we'll point out some of the key links to some specific information within that as a follow-up to the webinar. And Greg, also feel the need to apologize to you for taking some of your beautiful charts away from you. Promise we weren't trying to mess with you, and we certainly wouldn't have done that to Jason. But everyone has access to the slides through the copy of the presentation that was shared with all participants. So everyone, please make us feel better and spend some time looking at Greg's charts. So with that, just to start us off on the questions, picking up on the marriage counseling theme. You all obviously made a key decision at the outset to define the qualified applicants as these performing provider systems, and you've talked a lot about the importance of collaboration consistently throughout the presentation. Curious to what extent in regions where you have where you may have multiple PPSs, are you seeing any evidence of collaboration across separate and distinct performing provider systems?
Yes, good question. We have been strongly encouraging it. So like in places like New York City where you have high density and so you have lots of Medicaid members, we never envisioned that we would have, say, a single PPS in Queens or in Brooklyn. So there was always going to be more than one, and we do have some really good examples of that. I wish I could say that it's happening in every part of the state where you have more than one. But I think it's more the rule than the exception, or it's more the rule than the exception that folks are, in fact, trying to collaborate. So in the case of Brooklyn, for instance, where we have multiple PPSs, they came together and they agreed to do a single borough-wide community needs assessment. That's important because there's 1 million people living in Brooklyn who are on Medicaid, and we always were going to end up with more than one PPS. So they have done that. We also, what's happened is that in Brooklyn and other places, they've also agreed, since they do the same community needs assessment, they also agreed to basically implement the same projects, because invariably their networks have overlap. So you have a provider that's in more than one PPS. And the one challenge, and the thing we've always been nervous about, is a provider who's in 2 PPSs being looked to by these 2 PPSs and told to implement different projects. And one of, I think, the lessons learned from Texas is you want to avoid DSRIP burnout at the downstream provider level. You don't want your federally qualified health centers to throw their arms up when they're being asked to do too much. It was a key reason why we limited the number of projects to either 10 or, in the case of certain PPSs, 11 projects. And then, what our concern was, when you're going to have more than one PPS in an area and you could have overlapping networks, the chance was you could go all of a sudden to 20 different projects and providers having to do too much. So I think generally the providers have worked together, or the PPSs have worked together, and there's a lot more overlap. But there's still more work to be done in this regard, right? So there's flexibility within each of the projects in terms of how you go about implementing them. And so the next stage we have to continue to be vigilant on is to make sure that the PPSs are implementing projects in similar ways. We want to try to minimize to the degree we can, inefficient use of time, whether that's too much reporting, duplicative work, all those kinds of things that could happen in a multi-PPS environment. So while we have said all along it's going to be challenging in the communities where there is more than one PPS, that's why we've been encouraging communities where possible. And in fact, a lot of those federally qualified health centers and primary care providers and community-based behavioral health have strongly encouraged the larger systems who are forming these PPSs as the leads, strongly encourage them to come together in a single where possible. But in those areas where we don't have a single, I think we're going to have to continue to stay on top of this and make sure that they are working together in terms of implementation.
Great, thanks, Jason. Just following on sort of the theme of potential of wanting to avoid district burnout among providers and thinking about how this flows down to individual level providers, we received a bunch of questions about kind of how the payments flow to providers and whether or not the state has determined kind of the flow of funds and allocations, or if that's up to the PPSs themselves. Excellent question. So we have basically left it to the PPSs to negotiate it. We've given out guidance and suggestions about how those funds could flow. So for instance, we've sort of suggested that those funds could flow based on a few different sort of primary buckets. Bucket number one is reimbursement for costs incurred as part of implementing these initiatives. So you're implementing 10 projects. You're going to be those projects implemented on sites or within providers across the geographic area. They're going to incur costs. You want to find ways to compensate for those costs, particularly costs that can't be reimbursed through the traditional reimbursement systems. So that's always sort of, in our view, sort of, category number one. Category number two is subsets of the providers here are going to see reductions in revenue and need to go through a period of transition, including downsizing certain capacity, maybe building up other capacity. And during that period of transition, there's going to be what we're calling revenue loss, which is they're going to have shortfalls in revenue because of reductions in avoidable hospital use. They need some assistance during periods of transition to maybe take some of that inpatient capacity offline. And so that is a legitimate use of funds, particularly in the early years of the initiative during some of the more significant infrastructure changes. And then lastly, there has to be a clear component around quality. We think that everyone in the PPS should gain when the PPS overall is successful. And in addition, so that means there has to be a P for P component that goes out to everyone who's actively involved in implementing these initiatives and part of the PPS's collective effort. But also we think there needs a component, as Greg talked about, there's this quality pool, right, or bonus pool. If you exceed expectations, either you narrow that gap to goal by 20% as opposed to 10%, or you reach the statewide or within 90% of the statewide goal, and the PPS can gain additional funds. You want to encourage PPS network providers to go beyond, right, and not just simply do the minimum necessary to hit the next benchmark. And so we think it's important that PPS take that into account. But we have not dictated it. We've, engaged from time to time in terms of as the negotiations have gone on. But generally speaking, the PPSs have been sort of able to work it out ourselves, and we anticipate that each of those agreements will be a little bit different, but hopefully they'll be along the lines of what we've been describing.
Thank you. And I think another key part to that, Allison, is that part of this whole spectrum really also comes down to the patient level, the community organizations that interact with the patients. And so as far as success, it's not just the major institutions or the main clinical providers, but given that so much of what is avoidable in terms of unnecessary, hospitalizations really has to do with social factors. And those community-based organizations and interventions are key. And we are looking for that involvement in each PPS application, as well as how the PPS would devise a flow of funds or tap into existing reimbursement systems such as health homes.
Thanks, Peggy, and great to hear your voice on the webinar as well. So we probably only have time for one, possibly two more questions. We've received a bunch of questions around sort of the role and alignment with the prevention agenda through DSRIP. One of the slides mentioned earlier highlighted, I believe one of the project domains is around prevention. Can you speak to, from a leadership perspective, how you view prevention as fitting into the DSRIP framework?
Yeah, sure. So this is actually an interesting element of our conversations with CMS in negotiation. So usually CMS is eager for Medicaid waiver funds to be used to the benefit of the Medicaid population. It's usually loath to see those funds go outside of the Medicaid space. But in our discussions back and forth, we made the case that the creation of a provider system, the mission of a provider system has to be about more than just providing medical care. It has to be about trying to get communities to begin to address not only social determinants of health of a subset of the Medicaid population, but also to start thinking about the public's health and what can be done collectively to improve the public's health over time. Now, a lot of these public health interventions are not things that you can necessarily move the needle on quickly. But what we wanted to do is carve out a part of DSRIP to get these groups of providers to work together with a broad array of stakeholders to start launching these public health initiatives as part of this effort. Our hope is that this is a legacy that will continue well into the future. You'll have these providers who have worked together successfully on some of these public health initiatives that they will launch, but as they see success there, they will move on to other public health challenges in the community. It opens up the possibility for benefits far beyond the Medicaid population. It's been interesting to see the PPSs thinking about which of the prevention agenda initiatives to choose and therefore to move forward with based on the needs of their community. And it's so often the case, public health interventions are some of the most underfunded things in state budgets. They're just, at the end of the day, when you figure out how you're going to allocate the funds in any state's budget, oftentimes public health gets, the short end of the stick. And what DSRIP does is it really injects into the prevention agenda monies that otherwise would not have been available. And we will have a lot more activity in these areas and hopefully success because there's still performance measurement here. And so we're excited. I mean, I was just down in New York City yesterday talking to the New York City Department of Health and Mental Health, where we were talking about possibly, while there's each PPS in the city has been picking their own, there's only about 3 different public health strategies that are being deployed, and how the city, working with the state and all the PPSs, could potentially get each of those 3 public health or prevention agenda strategies really successfully deployed all across the city of New York. So we could address things like reductions in smoking rates, ending AIDS as an epidemic, and other public health goals, all achieved simultaneously, which would be a really exciting opportunity to leverage the infrastructure we're building with DSRIP to really meaningfully address some of these, public health objectives.
Well, I just want to take the last minute or so that we have here to thank you all, Jason, Greg, Peggy, and again, our thanks to David Sandman and the New York State Health Foundation team for sharing your time and all of this information with my colleagues and myself here at the Center for Healthcare Strategies and all of the participants from across the country, including many in the state of New York who apparently just cannot get enough DSRIP and cannot get enough information on DSRIP. So thank you to all for your your questions. I know we did not have time to get to all of them, but as promised, we will be sending out a series of follow-up information, including links to information on the DOH website and specifically the DSRIP page that provide answers to many, many of your questions. So thank you all for your time. Again, Jason, Greg, Peggy, thanks so much for your willingness to share so much, not only of the details, but also, most importantly, the lessons learned from your experience to date. I'm sure I'm speaking for everyone when I say that it's invaluable for others to be able to piggyback on your efforts and build from there. So thank you all again, and we will adjourn the webinar for today and look forward to future opportunities to convene you all and to share further insights on exciting delivery system reform opportunities.
Thank you very much.
Thank you.
This does conclude today's conference. Thank you for